The defense functions of blood. Here we have two topics. One is about hemostasis, and second about the immune defense function of the blood. So we start with hemostasis. Hemostasis is the stop of bleeding, and hemostasis may have two mechanisms. One is called platelet mediated hemostasis. Platelet mediated hemostasis. And the second is called blood clotting. The difference between them is, for example, maybe explained by the lumen of the blood vessel that is damaged. So platelet-mediated hemostasis takes place first of all in the small blood vessels and small arterioles, which may constrict efficiently, because the first phase of this hemostasis is when the part of the wall of the blood vessel is damaged. Collagen is propulsing in this lesion, and positive charge attracts negative the surface of form elements that has a negative charge. For example, the erythrocytes, they have negative charge on their surface. That prevents the mechanical interaction between different form elements, because they repel from each other. So it's good, it's normal. If there is a lesion, then this positive tissue proteins attract the platelets and attract red blood cells. The next phase of this hemostasis is so the first is aggregation of platelets. So this is a lesion, and the platelets, they produce like a crowd here. Next phase is activation of platelets. So they begin to produce biologically active substances. For example, serotonin, thromboxane A2, and ADP, and other factors that induce vasoconstriction. So next phase is vasoconstriction. So this blood vessel constricts, decreasing the blood flow through this blood vessel, and it decreases the blood loss. Is very important. Next phase is activation of platelets and the change of their shape. So the platelets, they change their shape. They produce such processes which help to keep each other in place, fixing this thrombocyte clot safely. So, and as a result, the white clot is produced in this blood vessel that stops the blood flow. So in general, this looks like that. So the different idea is about blood clotting. Blood clotting is initiated also and may stop the bleeding from large blood vessels. For example, in middle or large arteries where blood flow is intensive and the lumen is huge, and here we have no possibility to constrict, because such blood vessels do not have smooth muscle or even if they have, they cannot efficiently constrict. So in this case, we have the cascades of reactions with participants of plasma and tissue factors. So the most important factor in this case is fibrinogen. Fibrinogen, we may illustrate this idea like this, is a protein. So it's plasma clotting factor number 1 first. So it has a special part of the molecule. It looks like here like a cap, that when it is discarded, then fibrin is produced, and fibrin may bind. So the fibrin molecules, they are combined in such chains. So fibrin that produces a meshwork and stops the bleeding from this large blood vessel. So to convert fibrinogen to fibrin, we need thrombin. Thrombin is produced from prothrombin. Prothrombin. And prothrombin is activated by the number of factors. So together these reactions, they may be illustrated by this picture. So first factor is fibrin, is activated by thrombin, and we have the chain of factors which are divided into number 12, and then moving down 11, then it should be 10, but it's 9, and then it's nevertheless 10th factor. So to activate thrombin, we need also factor 5. And also factor 4, which is calcium. So calcium is very important thing for blood clotting. If we will add sodium citrate, it will bind calcium from blood plasma and blood will not coagulate. So citrate or ADTA eliminates calcium from blood plasma, and such blood is not coagulate anymore. Okay, so for this cascade, also we need some factors which are also factors number 7. Factor 3 is called also tissue factor. So this tissue factor activates factor 7, and 7 and 9 together, they are needed to activate factor 10. So and also we have factor 13, which is needed to produce the fibrin meshwork. So this fibrin strands, they bind each other with the help of factor 13. So these cascades are needed for amplification of this signal. This is if we have for example one molecule of factor 10, it may activate 10 molecules of factor 2 of thrombin, and each molecule of thrombin may activate 30, for example, or 50 molecules of fibrin. So this is a huge activation of this cascade. So, and we have also the loops of stimulation, like, so second factor thrombin activates factor 13, second factor activates factor 11, and factor 7, and also we have activation of factor 8, which should be here. So now it looks like that. So actually we have two processes here. We have so-called extrinsic way. Extrinsic, it looks like it works like a spark. So the tissue factors, when they occur in the blood, it gives a spark. It's rapid, but it cannot support this process for a long time. And we have intrinsic way, intrinsic and extrinsic. Intrinsic way is a working horse of blood clotting. Intrinsic and extrinsic way of blood clotting. So spark activates, extrinsic way activates blood clotting, and intrinsic keeps it working till the fibrin meshwork will be produced and will safely stabilize the clot. So it was about the blood clotting, but also we should say something about anticoagulation system. Anticoagulation system that is including many factors which inhibit coagulation, and for example, heparin is a factor of anticoagulation system. Heparin, so anticoagulation system. For example, heparin, also antithrombin 3. So these factors are included into the primary anticoagulants. There are also secondary anticoagulants. They are produced in the time course of blood clotting. So for example, when fibrin clot is produced, some chains, some parts of fibrin are released into the bloodstream, and they serve as a secondary anticoagulants. What for? To stop the blood clotting when clot is already formed, to inhibit this process, because clots may be dangerous. This is the general idea for anticoagulation system. When clots are produced somewhere where they not needed, they may block the circulation and may induce stroke or heart attack or any other necrosis into tissues. There is also the system that we call fibrinolysis. Fibrinolysis. This fibrinolysis is the system that destroys the fibrin clots. When they are not needed anymore, when the recovery and regeneration replaced the area that was damaged, the clot should be eliminated. So for that sake we have plasmin. The plasmin is the most important enzyme. Plasmin. It breaks fibrin. So plasmin converts fibrin into the soluble peptides, fibrinopeptides, which washed out from this area. So plasmin is produced from plasminogen. Plasminogen progenitor of plasmin, and we may have several mechanisms that may block or stimulate this conversion. We have also special drugs in the clinical practice that may facilitate or inhibit this conversion and may produce an effect upon fibrinolysis. Okay. And the second part of defense functions of blood, as it was mentioned, is concerning the immune mechanisms. In this topic, we should say something about the blood groups. So we have different antigens on the surface of form elements that determine the blood groups. We have many blood groups. We have more than 200 known blood groups, but the most important classification is called ABO system, and also rhesus factor. So in accordance with ABO system, we may distinguish 4 blood groups. The difference between them is in the agglutinogens and agglutinins. So agglutination is agglutinogens and agglutinins. So agglutinogens are on the surface of the red blood cells. They may be A and B, and agglutinins are antibodies which may be found in the blood plasma, and they may be alpha and beta. Greek letters. So first blood group, which is called also O, so because it contain no agglutinogens, but this blood group can contain agglutinins alpha and beta. So what will happen if agglutinogen A will be mixed with agglutinin alpha? So there will be the reaction between them. They bind to each other, and to this agglutinin alpha, another agglutinogen A will bind, and maybe another. So this will induce the reaction of agglutination, attraction of red blood cells. They will produce such group which will not be able to circulate properly and will block the circulation and will induce the severe consequences, even the death of the body. So they should not be mixed in one blood. Okay, so second blood group, which is called B. Second is called B because it contains agglutinogen B and agglutinins alpha. Third blood group, second blood group contains, it is called A, contain agglutinogen A and agglutinins beta. Third is called B, contains agglutinogen B and agglutinins alpha. And the fourth is called AB. It contains both agglutinogens and no agglutinins. Okay, so for blood transfusion, we should choose the same blood group. So if the person has a blood group A, we should use donor's blood, also type A. But also we should take into account rhesus factor. So what about the rhesus factor? On the surface of red blood cells in European communities, 85% of population is having an antigen, the complex of antigens. The most important is antigen D, factor D. So such blood is called rhesus positive. If D is absent, then it is rhesus negative blood. And if we will not take it into account, it may lead to the rhesus conflict. There may be two situations. First, during the pregnancy when fetus is positive and mother's body is rhesus negative. So what will happen? First pregnancy is normal, but during the second pregnancy, placental barrier during delivery usual. So during the first pregnancy, when there is delivery, the barrier is not quite safely stops the contact of rhesus factor of antigen D with the mother's immune system, and mother's immune system produces antibodies against D antigen. So during the first pregnancies, usually everything is okay, but during the second pregnancy, the mother's immune system, if the fetus is again positive, will produce aggressive antibodies, and it may even be a serious problem for the pregnancy, for the fetus. So to avoid this, after the delivery, if mother is negative and fetus is positive, we should use special antibodies to bind antibodies against this antigen D. It should be done during the first week after the delivery. So it was the rhesus conflict during the pregnancy. Second situation, rhesus conflict during the blood transfusion. If the patient is rhesus negative and the blood is given that is rhesus positive. So this positive blood, if it is the first transfusion, first contact, then nothing will happen because there is no preliminary antibodies against this D antigen. But if it is a second contact with antigen D, then the organism of recipient, it has B memory cells, which releases immunoglobulins very quickly, and which will attack these red blood cells of a donor's blood, and they will be destroyed. So it will be again severe hemolysis and rhesus conflict. So it should never be done. So it should be avoided. So now several things about how the donor's blood should be transfused. So we told already that it should be the same blood group in donor and recipient. But before the transfusion, if you are sure that the donor's blood and the recipient's blood has the same blood group and the same rhesus factor, you should perform several tests for compatibility. First test should be done in vitro on the plate. You should mix the blood of donor and the blood of recipient, and you should carefully observe for absence or presence of agglutination. So why these two bloods may produce agglutination? The question. Because there may be incompatibility due to other blood group systems that we didn't take into account. For example, for Kell or Delphi system, San Diego system that we didn't checked for our donor and recipient. So if this probe is okay, there is no agglutination, we may start blood transfusion, but we should do another test before it. We should add a little amount of blood, 10 ml of donor's blood to recipient, and wait for 10 minutes, 10-15 minutes, looking for unpleasant symptoms, headache, dizziness, vomiting, or anything else, some stomachache or anything that should be the reason to not to continue the blood transfusion. If this probe is successful, there is no negative signs, only then we can start the transfusion, but the volume of blood should not be large. It's only about 250 to 200 ml, not more. again, because there may be incompatibility due to other blood systems that we didn't take into account.